we're going to go ahead and get started. I want to welcome everyone to the webinar. I am your moderator and host, Dr. Lauren Levine. We had a great turnout, close to 700 people registered, fantastic speaker as always, great content. As I've been doing for the last few years, I hope that everyone is staying healthy and safe out there. I commend you for being here this evening. We know how busy you are. We know what a topsy-turvy couple of years it's been, but of course, the need for education really never ends, and of course, you're showing that by being here this evening. I'm only going to speak for a few minutes. I want to make sure that Ara can speak for as long as he needs. We want to make sure that we leave time at the end for questions as well. Most of you have been on these webinars in the past, so you kind of know how the format goes. You know, our speaker will talk for a little bit. Kurt from Golden Dent will come on for a few minutes and make a few offers, and then we open it up for the Q&A session. We don't take verbal questions, obviously, when we have 700 people on. So on your screen, you have a GoToWebinar control panel. Type in your questions as you think about them. I never know how many questions we're going to get. Sometimes we get 7, sometimes we get 107. I'm going to do my best to get to as many questions as possible. We have a hard stop, usually 90 minutes after the webinar starts. But you know, I see the questions. I'll be able to combine some together if we have a lot. And please feel free to ask away, and I'll do my best to get to all of them. In the next few days, look for a couple things. First off, this webinar is being recorded. You will get an email link that you can download or watch the recording. So don't worry if you got to take a call, you got to get distracted. You're not going to miss anything. During the webinar, Dr. Nazarian is going to be showing some systems, some products that he uses, which are exclusive to Golden Dent. As always, I want to thank them for their sponsorship of these webinars. They're the ones that bring in these great speakers. They're the ones who work with the speakers, develop the content, and they're the ones that handle the CE. Speaking of the CE, I always get emails after the webinar asking about CE. I'm going to try to mention it at least 2 or 3 times this evening, is that if you stay on for the webinar, you will get a CE form. There's nothing you need to do. There's no test. There's nothing you need to fill out, no registration. As long as you're here for the bulk of it. We've had some people that come on for like 4 minutes and then don't understand why they didn't get a CE form. It doesn't work like that. But as long as you're here for the bulk of the webinar, you will be sent a CE form. With this many people, it can take a week or so for those CE forms to go out. So, check your inbox, check your junk folder. If you don't have something, say, by this time next week, feel free to shoot me an email and I'll follow up and make sure that they know you're still waiting for it. So it thrills me once again to welcome Dr. Nazarian. We were just talking earlier. We think this may be around our 25th webinar that we've done together over the last few years. He maintains a private practice in Troy, Michigan, with an emphasis on comprehensive and restorative care. He's a diplomat of the International Congress of Oral Implantologists. His articles, if you read dental journals and you've seen his articles, they've been published in many of today's popular dental publications. He's consistently listed as a top dental educator. He's conducted many lectures and hands-on workshops on aesthetic materials and implants, extractions, grafting, and tonight endodontics throughout the world. He's the lead faculty for Amplified Dental Training, which teaches atraumatic extractions, grafting, immediate denture, dental implants, and endo. So, Ara, we're thrilled to have you back, and please take it away.
Great. Thank you, Dr. Levine. And welcome. This evening, we'll be talking about endodontics for the GP. Usually when patients present to your practice for an emergency, there's one of 2 things going on. Either there's severe decay causing tooth sensitivity, or there's decay that's causing some type of infection or abscess. So our goal is to deal with these patients. In our office, the rule is to take all the patients that call in for an emergency to at least take a radiograph, see what's going on, and get them on an antibiotic if we can't do the procedure that day. So it's imperative to treat our emergency patients as emergencies. Don't have them wait. Let them come in, get an x-ray, and treat them if you can. Otherwise, get them on some type of antibiotic. The majority of the toothaches that do come in, I would say about 80% of them, usually need some type of root canal therapy. And I'd say probably the other 20 to 25% would need extractions. Usually these are the 2 types of emergencies that we're dealing with in our office. Now, if you're fitting a person into your schedule that does need a root canal, then it's obviously imperative to try to do this as quickly as possible, as effectively as possible, and as predictably as possible. So the key here is to be fast, effective, and predictable. We all know how to do root canals, but we want to be fast, effective, and predictable when doing them, not only during an emergency situation, but also if we have them scheduled within our appointment book. We don't want this to be a 2.5-hour procedure. Normally in our practice, if we're doing a root canal, a molar root canal, and a core, we're doing that within an hour from start to finish. So at that point, you can always reschedule them to come back for the crown preparation. Once you have the core in that tooth, make sure it's out of occlusion so they don't crack the restoration until they come back for the crown preparation. Well, what are the signs that a root canal is needed? Sometimes the patient will present with no signs at all, but usually what we see is there's going to be severe tooth pain upon chewing or application of pressure. There may be a prolonged sensitivity or pain to hot or cold. In other words, after the stimulus is removed from the tooth, the pain lingers on and on. So it doesn't just go away within 10 seconds of taking something that's cold off the tooth, but in fact, it lingers on for several minutes. Sometimes a tooth can be discolored, or you'll see darkening of a tooth that had trauma years ago, and then all of a sudden the tooth finally starts to hurt the patient. We may also find swelling or tenderness in the gums nearby, or see some type of reoccurring pimple or fistula. So these are some signs that we as general dentists can easily identify when the patient presents to our practice. Of course, these are some clinical findings that we would have, but most importantly, we would also look at radiographs when deciding whether or not a tooth needs endodontic treatment. Well, let's just say the patient does need endodontic treatment. My goal is to educate these patients and let them know usually it's going to be involving 3 steps. And sometimes these 3 steps can be done in one appointment, and sometimes it may be divided into 2 appointments. It all depends on the timing of this patient. In other words, do we fit them in between several scheduled patients? Or was the tooth severely abscessed that we wanted to wait before we finished the root canal? Or lastly, was the tooth just so broken down that we didn't have time to do a core buildup, so we just put a temporary restoration within the tooth until they come back and then take care of it at that time. But the important factor to keep in mind is that there are 3 steps involved when I identify this to the patient. The first step involves removing the decay and or the infection. The second step involves doing the actual root canal and doing some type of buildup. And sometimes it may have no post. Sometimes the core may have pins, or sometimes the core may be on its own. But step 2 is usually rebuilding the tooth to a certain extent after it has been root canaled, started and finished. And then the last step obviously is cuspal coverage or having some type of crown restoration on that tooth. So when we inform our patients of the various treatments that are involved in root canal therapy, we break it down into these 3 steps. And by doing it in this fashion, the patient doesn't get overwhelmed. They understand what we need to do in layman's terms, and using pictures such as these, the patient can easily understand, yeah, I understand. Okay, you're not just going to put a big filling in this tooth. You, in fact, are going to do this core, but then I need to come back for the crown restoration. Otherwise, the tooth can crack. So again, our rule is emergencies are always seen the same day. It doesn't mean we're going to actually treat that emergency with a root canal or an extraction. My goal is usually to try to do that 75 to 80% of the time, but at least see them and get them on some type of antibiotic. Here are some examples of emergencies that were seen the same day between my normally scheduled patients. And so this patient presented with a loose bridge. The posterior or distal abutment tooth was severely decayed to where the bridge was teeter-tottering on this anterior abutment. And so it was causing the patient quite a bit of discomfort. So we easily removed the bridge. It was already loose, did the root canal therapy, as you can see on the prepared tooth. And then, as you can see, there's not enough tooth structure to just put a core. So we actually removed 2/3 of the gutta percha, created a post space, and cemented a fiber post and did our core buildup. This way, when the patient left, they left with just a temporary on that tooth. And we said we'd have them come back for treatment planning, and we would scan the area to see if we could possibly put a few implants distal to this tooth so that they would no longer need a bridge. In fact, they no longer had a distal tooth after this appointment anyway. Here's an anterior case. The patient had presented to her dentist. He had done some crown restorations. The patient kept complaining that there was severe discomfort on biting and any type of function. Their dentist had adjusted the crowns on the lingual surface several times. However, the pain did not go away. So when the patient finally presented to my practice, we went ahead and did the root canal therapy on tooth number 8 and 9. This was probably about a half-hour procedure in between patients, but using the methods and some of the instruments that we'll identify this evening, you'll see that you can also provide endodontics that are fast, effective, and predictable. One of the ways that we explain to patients when things are going on is this patient education model. I did help create this, and this is distributed by Golden Dent, but it's called Demo Dent. This patient education model illustrates socket after the tooth has been extracted, occlusal and interproximal decay, a failing amalgam restoration or margins that are leaking, and then finally you can see the blue indicates the core restoration, and then the crown that goes on there. On the reverse side, you can see the crack in the tooth in the lower right-hand corner, as well as recession or tartar buildup. So what I found over the years, patients understand things if you show them and illustrate it to them. So using these types of models, an enlarged tooth that's about 2 to 3 inches in size, patients understand it much better, and seeing is believing. So once the patient understands it and comprehends it, then they're more inclined to accept treatment. Now, we're ready to do a root canal, let's say. The most important thing is making sure the patient gets fully anesthetized. We've heard it several times from our patients in the past that the last time somebody did a root canal on them, they didn't get fully numb, and it was a horrible process, and they haven't forgotten that. So it's imperative that we get our patients fully anesthetized. And so we'll review a few different options that are out there. So when nerves are on fire or there is a hot tooth, then these patients do become difficult to numb because there may be an abscess, it just may be an aggravated tooth. So when they're in an excited state, these nerves require obviously more anesthetic or more potent anesthetic to get these patients numb. So one method that I utilize if there is a hot tooth or a stubborn tooth that is difficult to anesthetize is to use a Pdl injection. This is an intraligamentary anesthesia method. What you're doing usually is with the bevel oriented toward the root surface, you're advancing the tip of the needle into the Pdl between the root surface and the adjacent bone. So you're administering a small amount, maybe 0.2 to 0.3 millimeters of anesthetic solution slowly. You're going to see that there will be resistance. You actually want there to be resistance. So to ensure the solution is being forced into the tissue, you need to feel this resistance. So if you're dispensing the anesthetic and you see it just flowing all over with no resistance, then you do not have the needle engaged in that area between the Pdl and the bone, and you're not putting enough pressure. A lot of times I'll bend like a 27 gauge needle, bend it a little bit, and that way I can put pressure with my index finger or my thumb on the needle to engage into the PDL space. So this is one way to anesthetize your patients when they do have a hot tooth. Another method is something called the X-tip or intraosseous anesthesia. So what we find, especially in the lower arch, is denser cortical bone. And so when there is dense cortical bone, you're not going to get the infiltration of anesthetic like you do in the maxillary arch. So the principle of this intraosseous anesthesia consists of placing the anesthesia solution directly into the cancellous bone. So by using this sort of little tunnel or sheath that you drill into the cortical bone between the roots, obviously, and obviously you don't want to penetrate through a root, you will cause damage, obviously. So you're going to make sure that this channel is placed between the roots. And then once that is positioned, then you can easily find it with the needle that comes with this kit and numb the teeth. You'll get a very good duration, and the effectiveness is really quite immediate. The patients will feel the pressure as you dispense the anesthetic through this intraosseous channel, but they do get very numb very quickly. And so sometimes this works even better than a block because it's immediate and we can get right into the tooth. And then if we need to, we can go into the pulp chamber with anesthetic if necessary to confirm that everything is numb. But this works, I would say 9.8 out of 10 times. Another way to use that, there's something called the Stabident. The Stabident uses the same type of method, which works quite well. However, there's no channel. So there's a variety of different methods. You can find some more on the Golden Dent website. So once we've anesthetized our patients, it's essential to isolate that tooth. We want to isolate the tooth so that the patient doesn't swallow any infection that may be coming out. But more importantly, when we're placing small files and different types of medications or solutions in the tooth, we don't want the patient ingesting these things. So it's essential to have some type of barrier system. Obviously, the most common is a rubber dam with clamps. They have a variety of different materials. If somebody is allergic to latex, they do have latex-free rubber dams. And then they also have rubber dams that also have the built-in frames like these flexi dams that work quite well. Okay, so we've anesthetized the patient. We've isolated the tooth. We want to know or have an idea of the anatomy and the locations of the pulp chambers when going in for endo access. This is a great chart. You can find these online, and it quickly identifies, let's say, a first premolar, the anatomy of what you would be looking for in most of the cases in these types of teeth. Anterior teeth, posterior teeth, or premolars, you name it, you have an idea of where the pulp chambers are. Here's another drawing or schematic that also identifies where you would be finding the canals. And so this is also very helpful to have in your operatory. It doesn't have to be in front of the patient, but it could be in back of the patient, just so you remember, okay, well, let me try to identify where these nerves are. I'm having trouble, maybe a calcified tooth. I need to look in this region. One thing you'll notice with all of these, you'll see an ISO number, ISO 50 or 60 for a central incisor. What do we mean by ISO taper? ISO stands for the International Standards Organization, and the taper is the amount by which the diameter of an instrument increases from tip to handle. So if we say something is ISO 50, it could be from a variety of different manufacturers, but it's sort of an International Standards Organization ruling of that taper. So you'll find that most gutta perches that say an ISO of 50 or 60 or 30 are going to be pretty much the same type of taper. So that's what we mean by ISO. So if we look back here at these teeth, you can see that an anterior central maxillary incisor usually is going to have a taper in an ISO 50 or 60. And so if you're only going in there with, let's say, an ISO 25, then I would guarantee you didn't get the whole chamber cleaned out or the canal. So these are also another good guideline to utilize when doing root canal treatment. So let's take a look at a variety of the different teeth that we need to work on. If we look at the maxillary central incisor, we know that we're going to make the access opening look something like this, either oval or triangular. And so we know that the average length, according to this reading here, is 22 to 23 millimeters in length. And we know that 100% of the time, a maxillary central incisor has one canal. If we look at a maxillary lateral incisor, we know the shape of the access opening is going to be oval, and we know 99.9% of the time it's going to have one canal and be about the same length, 22 to 23 millimeters. If we look at the maxillary canine, note, we know that that's going to be long. So these rotary files come in a variety of different lengths. You want to make sure that you also have some that are long to be able to engage some of these canines and do the root canal therapy to its fullest length. Also, the access opening is oval. So most of the anterior maxillary teeth, an oval access opening is going to be sufficient. You'll notice in the maxillary central incisor, usually I'll tend to go more of a larger oval or even triangular in shape to complete the removal of the pulpal tissue. Looking at lower incisors, we know that the mandibular central incisor, we're going to keep the access opening oval, but we see that there's one canal and one foramen 70% of the time, but 24% of the time there may be two canals and one foramen, and 6% of the time there's two canals, two foramens. So usually you're going to find one canal, one foramen, but every now and then you will find that there may be either two canals and one foramen or two canals and two foramens. With the mandibular lateral incisor, the access opening will be oval, but we'll see only 56% of the time there's one canal, one foramen. However, 30% of the time there may be two canals and two foramens. So that's important to keep in mind that the lateral incisor is, lower incisor is the one that may give you some trouble. And then obviously the mandibular canine access opening is going to be the same. However, the length of that root is going to be 26 millimeters in length. So again, you will need longer files for the canines. One canal 94% of the time. So that usually doesn't give us a problem. Looking at premolars, the maxillary first premolar, again, our access opening is going to be oval, but it's going to be broader going buccolingually than we go mesial distally. And so here you can see that there's one canal, one foramen, only 9% of the time. Usually you're going to find two canals and two foramens with a maxillary first premolar. With a maxillary second premolar, usually you're going to find one canal, one foramen 75% of the time, where 24 to 25% of the time you may see two canals, two foramens. So it's important to know, usually it's the maxillary first premolar that may give you some trouble having a second canal. Looking at the mandibular first premolars, again, our access openings are oval, going broader in a buccolingual direction. And so the mandibular first premolar has one canal, one foramen 73% of the time, where the mandibular second premolar has one canal, one foramen 86% of the time. So it's usually the first premolars that have the extra canal. Now, let's look at maxillary first and second molars. The maxillary first molar is the one that gives a lot of general dentist trouble. We're aiming for three canals and there ends up being 4 canals. So this number is very important. 56% of the time there are 4 canals. Usually general dentists will only find the 3. So it's important to find that 4th canal because you'll see it 56% of the time. Usually the average length of a first upper molar is going to be between 19 and 20 millimeters. However, there will be exceptions to this, but usually, it's going to be in that vicinity of dimension. If we look at the canals, we'll see that there will be 1 canal, 1 foramen 40% of the time for the mesial buccal area canal, or 2 canals, 1 foramen 40% of the time. So it's obviously the mesial buccal area that gives a lot of general dentists difficulty. So having magnification is imperative, and usually that's the area you want to look a little deeper and see, is there actually only 3 canals or is there a 4th canal? Looking at a maxillary second molar, usually we'll find the number of roots, 3 roots, usually 54% of the time, but 46% of the time we'll see that they may be fused. And so in this particular case, the mesial buccal canal, 63% of the time is only going to be 1 foramen. So usually you're only seeing 3 canals with a second maxillary molar. In the lower molars and the lower mandibular first molar, what we're finding is the access opening is not oval shape, but more a trapezoidal shape. It's going to be broader buccolingually in the mesial section, and then it's going to sort of taper in a little bit as we go to the distal. And so usually we see 98% of the time 2 roots, and in the mesial root, usually you'll find that there may be 2 canals or a total of 3 canals altogether. So usually here we can see the different dimensions and the different probabilities of running into 1 or 2 canals in the mesial or distal areas. In the mandibular second molar, usually we're finding the mesial canal to have 2 canals, 2 foramens. In the mesial, that's about 38% of the time, or you're usually just seeing 2 canals, 1 foramen. So it really depends on the tooth. The key to keep in mind is to identify the areas where you need to look, and we'll talk about the different rules to keep in mind. So practical techniques for endodontic access preparation. What are we talking about? Well, there's several rules that we follow to have a point that's repeatable. In other words, a landmark that's repeatable or to be able to use as reference. And so this first rule is called the rule of the cemento enamel junction. The cemento enamel junction is the most consistent, repeatable landmark for locating the position of the pulp chamber. So if you look at the green line, that's obviously the cemento enamel junction. And we know some of these rules that we're going to apply. The best area to identify is the CEJ when applying these rules. The first rule is the rule of centrality. In other words, the floor of the pulp chamber is usually located in the center of the tooth at the level of the CEJ. So if you take a burr and you drop it in the middle of the tooth, usually you're going to enter the pulp chamber. And then from there, you can use an endo Z-burr to widen it up to further identify the canals. But the rule of centrality again says the floor of the pulp chamber is usually going to be located in the center of the tooth at the CEJ. That's what we're usually finding. We'll tell you some of the exceptions to this in just a moment. The rule of concentricity says the walls of the pulp chamber are usually concentric or going towards the inside, following the shape of the root or the tooth surface. So in other words, the walls of the pulp chamber are usually concentric to the external surface of the tooth at the CEJ. So if you would slice that tooth, let's say hypothetically at the CEJ, and work inwards, looking at the shape of that tooth, that's where you're going to find the different areas of where the pulp chambers can be identified. So that is another rule to use. So we have the rule of centrality, and then we have the rule of concentricity. Now let's also look at the rules of symmetry. There's a couple of rules of symmetry. Now these do not apply towards the maxillary molars. However, it says in the rule of symmetry number 1, the orifices of the canals are at an equal distance from a line drawn in a mesial distal direction through the pulpal floor. So if you were to draw a line right through the middle of the tooth going mesial distally, and you find a canal that's probably 2 millimeters away from that midline on the lingual, it's highly probable that you will find the buccal, mesial buccal canal 2 millimeters away from the midline as well. So that is the rule of symmetry. So if you're drawing an imaginary line, mesial distal, and you find a pulp chamber in one area, then you're going to find the other canal at an equal distance from that midline. The rule of symmetry 2 says, and again, the exception is maxillary molars, but the orifices of the canals lie on a line perpendicular to a line drawn in mesial distal direction. So if you would bisect that first line that's cutting the tooth in half mesial distally and go perpendicular to that, then that would be another area where you would find the orifices. So it would be of equal distance from that midline, and it would be perpendicular of that line. So these are two areas to, or two rules to use to find the areas, because every now and then you will find one canal very easily or one orifice very easily, and you just can't find the other one, but you know it's somewhere there. That's when to use these rules. Also, lastly, you'll see the rule of color change. The rule of color change indicates that the color of the pulp chamber floor is always darker than the walls of the surrounding tooth structure. So when you access that pulpal chamber, you're going to find that the floor of that is always going to be darker. At that point, you know not to keep trying to drill apically, but instead use a safe side or burr or an Endo Z-burr, as Golden Dent provides, to place at the floor of the chamber. And since it's non-end cutting, you won't drill any further apically, but rather widen that access opening and identify where those orifices are. So let's look at this paper from Pdl and Rhodes. And in this paper, a practical guide to endodontic access cavity preparation in molar teeth, we're looking at pre-treatment assessment, preparation of the tooth for endo treatment, removal of the roof of the pulp, chamber and coronal pulp tissue, and then trying to create straight line access. So whenever we do pre-treatment assessment and we have the radiograph up, we want to look at this and actually study it. We want to look at the length of these roots, but we also want to look at how are we going to access this. Some people choose to take all the previous or existing restoration out first. Others like to do an ideal access preparation that is not convergent but divergent. In other words, if you look at it from the top going down apically, you should be able to see everything, so there's no undercuts. So this is the first thing we'll do when looking at a tooth on the radiograph before we access. The second thing that we'll look at is the length. So we want to do a pre-length assessment and confirm, hey, are these roots, is this tooth 25 millimeters in length? Is the tooth 35 millimeters in length? Is the root only 18 millimeters in length? We want to have an idea before we go into that tooth and access it. How long is it roughly, just by measuring it on our digital x-rays? So the two things I'll do for a tree treatment assessment is look and see where's my access going to be, and then also look at the length, and then also study the roots and see, hey, is this a tooth that I'm willing to take on, or am I going to refer this to the specialist? Again, we already mentioned this earlier in the evening, that it is imperative to use some type of magnification. And so here you can see rules 1 and 2 have already been applied. We're drawing an imaginary line mesial distally. We're bisecting that perpendicularly, and here we can identify where the two mesial canals are. Endodontic explorers are very important. Make sure yours are sharp and not broken. And then obviously access burrs. There's a variety of different burrs that are out there. In my armamentarium, I'm literally just using 2 to 3 different types of burrs. The two endodontic access burrs are either the PR1210 or PR1910. The only difference is the head, that's the round part, is either larger or smaller, and we use this to access. And once we've gone and accessed the pulpal chamber, and we'll take the endo Z-burr, place it down to the pulpal floor. We don't have to worry about drilling apically since it's a non-end cutting, and then we'll just open up the access opening. So here in the article, we can see A, B, C, and D. If you look, A is the starting, B is just dropping that diamond and until it drops into the pulpal chamber. Once it's dropped into the pulpal chamber, you can go with an endo Z-burr in pictures C and D and just widen up the canals, and then go in with your number 10 or 15 file to confirm length and everything. So again, we mentioned this earlier, we definitely want divergence of the access towards the coronal. In other words, when we look from the occlusal view, we can see all of the canals and all the openings. Okay, so we don't want undercuts. Looking at a side view of an access opening, again, you can see it's divergent from the bottom up. And so here we have a direct line access when filing, when rinsing, whenever we're doing the whole process in root canal therapy. Here's some examples of access openings that you can see. Notice the good visibility and accessibility. These are necessary to carry out endodontics. If you can't see what you're doing, you're obviously not going to do a good job. So it's imperative to get a good access opening. Well, this evening, our goal is to talk about providing endodontics that's fast, effective, and predictable. And I found that rotary files have been very important in the progression of endodontic therapy. It's definitely made it much more complete and effective in my eyes, and it's definitely made it more efficient. There's a variety of different systems that are out there. We have Endo Sequence, Twisted Files, Wave 1, and Pro Taper. I've used all these different systems over the years. The go-to and probably the one that's been on the market and used by a lot of specialists and general dentists has always been the Pro Taper Gold. That has sort of been the standard. Unlike other rotary systems that are available that use a fixed taper, the Pro Taper files have a variable taper. What does this mean? This means that it's not going to engage from the tip all the way to the stem of the file, and this way you get less separation. So by having variable taper and variable areas that are doing the cutting and shaping and filing, then you don't have binding and you don't have separation. So this has been around for many years. It was Pro Taper, then it was Pro Taper Gold, and I think they just came out with something else. It is a very good file. It's using a variety of different geometries, as we talked about, with the triangular cross section. But most importantly, it's got a non-cutting edge. It's just a modified guiding tip, and then obviously the various tapers. And the way it works is you have shapers and you have finishers. The shapers do the 2/3 coronal portion of a root, where the finishers do the apical third. And so they've been very, very effective over several years to be the gold standard. And so Golden Dent pretty much files are comparable to the Pro Taper. They use the same or similar techniques as the Pro Taper or Pro Taper Gold, but they're probably half, if not a third of the cost. So this is where we increase our savings as practice owners, and we just use the files once and discard them. So we don't have to worry about the wearing of the files or a separation of a file or the untwisting of a file. So Golden Dent pretty much is offering files that are quite comparable to the Pro Taper and Pro Taper Gold. And so if you look at the geometry as well as the design of it, it's very similar to the Pro Taper. And so here are the different files that you can get in a 6-pack, and they come in lengths of 21, 25, and 31. The most common size that I use is the 25, and then I do have the 31s in case we are doing canines. So if somebody says, well, what should I purchase? I would say the majority should be the 25 and the 31. 90% of your files in the 25 length, 31, probably another 10% only. So we have the SX, which is only 19 millimeters in length. This is the first shaper that's used. This helps open the orifice right at the opening. And so unlike other rotary systems, we're using this at about 300 RPM and about 5 or 3 Newton centimeters torque. The beauty with the Pro Taper system or the Golden Dent system is that because you're using various tapers, you're not as concerned about binding or separation of the file because the whole file is not engaging the canal. It's only various areas that are engaging the canal. So usually if you get a 6-pack, you're seeing the first 6 files. And then if there are larger canals, then you can go to the F4 and F5. So here we have the shaper, S1, S2. So these are all doing the coronal aspect or the first 2/3. And then the apical portion is being completed by the finishers. And that's what we mean by F1 and finisher F2. And if you're widening these up some more, we're going to see that with the F4 and F5. Okay. So let's look at some examples real quickly. Patient presents complaining of discomfort to hot and cold. It lingers for several hours. He mentions that the tooth is uncomfortable to chewing, especially when functioning on that side. Radiographically, we see there's a large carious lesion on the distal portion of the tooth number 31 under an existing amalgam restoration, and it is extending into close proximity of the pulp chamber. We also see the periapical lesion as well. So looking closely at this radiograph, remember this is tooth number 31. 30 is missing, and then the tooth behind that you see is 32. We explained to the patient using the DemoDent patient education model that we in fact have to remove the decay from underneath your restoration. It is extending into or in close proximity to the nerve. So because we see the radiographic lesion at the apex of the root or tip of the root, we are suggesting endodontic therapy. In some cases, you may not have a periapical lesion. However, when you do carious removal, you are in close proximity. So you may choose to do either A, a prophylactic endo, or B, place a base or a liner and do a restoration. So the choice depends on several variables, depending on what you see with your exact patient. Our pre-treatment assessment is to estimate the length of the roots. Here we can see these are somewhat longer. We're also going to identify where we'd be creating an access opening. We know for a mandibular second molar, our shape of the access opening is going to be trapezoidal, and we know that there's going to be at least 2 canals in the mesial portion and either 1 or 2 in the distal portion. We're going to initiate our endo access with a PR 12 or PR 1910. Notice the PR 1210 is a smaller opening. Usually I'll just go with a PR 1910, a larger opening, and then we'll go straight to the Endo Z once we've dropped into the pulpal chamber. Notice our access opening preparation. We're going to try and keep it as ideal as possible. And then later, once we've filled the tooth, we can go ahead and remove further decay. So step one, we're using our diamond burr to drop in through the amalgam restoration. And then once we've dropped into the pulp chamber, we'll use the Endo Z burr to widen that area. At that point, we'll use a 10 and work up to a 15. So a lot of people want to jump straight to the rotary file, but I do want to see you at least go with a 10 and a 15 file to make sure you negotiate the curvature of the canals and get to length with these files, hand instrument files first. So what are we doing essentially? We're creating an endodontic glide path. This is a smooth radicular tunnel from the canal orifice to the physiologic terminus or the constriction of the canal. Sometimes you can feel this by hand. Most of the time you're going to take a radiograph to confirm your length. So this is what we call a glide path, or we're doing glide path management. Irrigation is essential. It is often regarded as the most important part of endodontic treatment, in particular for the eradication of root canal microbes. Remember, a tooth is bothering the patient because it is infected, because microbes have infiltrated the pulp. So during and following instrumentation, it is important to irrigate because not only does it facilitate the killing of the microbes, but it also is removal of the microorganisms because it is flushing the microorganisms and the necrotic and inflamed tissue as well as the debris out. So what are some of the solutions that we have? The most highly used is sodium hypochlorite. A lot of times doctors try to mix their own and they never get the appropriate consistency, or they're using too much sodium hypochlorite and they're causing a lot of irritation and sensitivity to the apical tissues. In areas where we may have calcification, the 17% EDTA works quite well. And then we also have the EDTA with chlorhexidine if you want to further disinfect the tooth and clear any lateral canals. So what is the endodontic irrigation? Again, it's the most important. I can't emphasize that any more than that, but it is essential in endo treatment to kill and to rinse out the bad stuff from the tooth. The most commonly used irrigation is sodium hypochlorite, and usually 5 to 6% is better than any 1 or 2%. So this comes pre-mixed from Golden Dent, 17% EDTA for calcification, and then we also have the EDTA with chlorhexidine. They also offer a variety of different tips, 23, 27, and 30 gauge. Usually I'm using a 27 gauge in a 3cc syringe. Now it's important to identify and determine working length. Working length, if you're looking at a radiograph, is usually 1 millimeter shy of the radiographic length. According to the American Association of Endodontics, working length is defined as the distance from a coronal reference point to the point at which the canal preparation and filling should terminate. The minor diameter or apical constriction is the place where instrumentation and obturation should terminate. So what do we mean by that? Why are we not going by a radiographic apex, or why do we measure the canal and say, okay, well, this canal is 20 millimeters in length radiographically, so we're only going to work to 19 millimeters. And the reason for that is the radiographic apex does not identify where the anatomical apex is or where the apical constriction is. Our goal when we fill this tooth is to be somewhere between the apical constriction and the anatomical apex. And our goal when filing is to be at least to the apical constriction and not go further than that. And so this schematic clearly identifies why many times you may look at, let's say, an endofill that's come back from an endodontist and you go, wow, it looks like the endo's short, where in fact it's not, because you're looking at the radiographic apex, not at the anatomical apex or constriction. So it's very important to identify these different lengths and know where your filling material should be. In fact, when we're using an apex indicator to identify the length, this is also another way to get the length, your working length. So when you get the indication on your apex indicator, you don't have to subtract a millimeter for your working length. In fact, this is identifying what your working length is, because it's identifying where that constriction starts, not where the radiographic apex is. So it's important that our listeners know the difference. There's a variety of different apex indicators. Some of them actually can be within the handpiece as well. This is the woodpecker. This is also offered from Golden Dent, but they also have the woodpecker handpiece that has a built-in apex indicator. What should we know about electronic apex locators or indicators? The key is, if you're putting this file in and you put the little clip on the patient's lip, you need conductivity, and you don't want that conductivity to be altered by any type of metal. So if they have a metal restoration and that file is touching the metal restoration, it may cause there to be a false reading or inappropriate reading. So that's one issue that you may find. The apex indicators of today can have some irrigation in there. It can have some blood. They don't have to be bone dry like the first apex indicators that were available. So they work quite well. These are how the files come in the Golden Dent blister package. There are the 6. We have the shapers, and then we have the finishers. Here we have the AI motor from Golden Dent's woodpecker. And the beauty of this is, number one, you can get it with an apex indicator. Number two, it's got a 360 swivel head. It's cordless, so you don't need this huge motor connected to it. It's all there in the handpiece. You can see it's very easy to charge. You don't have to worry about assistants wiping this and causing an issue. Again, the mini head allows you to access posterior areas very easily, and it's got very nice torque, and it's a 6-to-1 contra angle. You see it's very operator friendly. So again, we have the shapers and the finishers. So we have several of these packs already pre-made for our patients. This way, if somebody comes in with an emergency, we're ready to roll. And so first we'll use the shapers in the 2/3 coronal portion of the root, and then followed by the finishers. If we find it's a larger canal, let's say a distal molar canal or a palatal canal, then we may finish up with an F4 or F5 finisher file. So here we'll use the SX to resistance. Remember, this first shaper file is only 19 millimeters in length. And it's important that between each rotary file that you do rinse, recapitulate, and rinse again. Otherwise, you do get the clogging of the apical region, and that's with any file system. This is where I find a lot of general dentists eliminate this step, and then they find that they have debris getting clogged at the apex, and then they no longer have the ideal length that they used to. So it's important to rinse, recapitulate, and rinse again. When you're recapitulating, you're using a smaller instrument to remove the debris produced during instrumentation. So we're not going to use a large file. We're going to use a small enough file that we can go and recapitulate the dent and debris in there. And also, this helps us prevent pushing debris beyond the apex, because sometimes you'll get some resistance and then people want to push harder with their rotary files. So here we see we're going through our S1 and S2 to length. We're rinsing and recapitulating between each step, and then we go to our finishers. And in this case, obviously, we're finishing up to an F3, which is equivalent to like a 30 size file. Okay, so we'll go ahead and rinse, recapitulate, rinse. Then we'll go ahead and dry. Golden Dent offers the paper points and gutta percha points that correspond with the golden taper files. And these are provided from Diadense for Golden Dent. And when we come time to obturate these canals, again, you want the obturation material to be somewhere between the constriction and the anatomical apex. You do not want it extruding out the root tip to the radiographic apex. So Endodontic Insight says, where should the gutta percha point end for optimal endodontics? And we say between the constriction, which is the C, and the anatomical apex. So what is obturation of a root canal? Essentially, it's filling in the empty spaces, promoting hermetic sealing, and preventing bacterial activity from infiltrating the periapical tissues. So it's essentially getting a good seal in the tooth. And so the material of choice is usually the gutta percha. It's been used for ages. It's very biocompatible and an inert material. And again, where do we stop this? At the constriction and anatomical apex, as indicated in the green section on the drawing. Diadense Pro Seal, which is also distributed by Golden Dent, is a great root canal sealer material. It's a 2-component epoxy resin system. It's got great sealing and adhesion to the gutta percha as well as to the tooth structure. It's got nice flow when using a lentillo. It's got a high pH value, so this means it's got great antimicrobial activity. It's not soluble very easy. It's not going to wash away very easily, but it is highly biocompatible if you do have the little spray of sealer coming out the apex. Most importantly, on a radiograph, it is radio opaque, so you can identify it very clearly. So once my assistant mixes this on a pad, we'll take our lentillo and use this to spiral the sealer. This helps get it to the apical area and to spread it throughout the internal surface of the root structure. So here you can see we filled the tooth. We also did the core buildup, informed the patient we will need to have them come back for a crown preparation. The core material that we utilize in our practice is the Wago core. The beauty is this is zirconium infused composite, so it's very strong. And we like the white color so that the patient comes back for their crown restoration. But more importantly, when we prepare these teeth, we can clearly identify where the core is, especially if it's a margin that's under the gum line, and where the tooth is. Usually when doing endodontic treatment, I like to give my patients a 4-milligram tablet of dexamethasone, or as we know it as Decadron. This helps with any type of inflammation. It also helps if their jaw was open for too long, but most importantly, it helps with the inflammation at the apex. Sometimes general dentists may over-instrument the tooth, and so the patient complains of discomfort. This usually helps reduce that discomfort. We usually will review post-op instructions with our patient. Taking a 400 or 600 milligram of ibuprofen helps for the pain. We want them to chew, only stick with a soft diet until the anesthetic has worn off, but still be careful around that tooth. And then obviously we want them to return for a crown restoration. So here you can see we've prepared tooth number 31. We even inform the patient if they want an implant in the 30 site, we can do it because they were so happy with our emergency treatment. We prepared the teeth, and using Cat and Box Panasil, we took an impression and delivered the zirconia cuspal coverage restoration. Here's some materials to choose from. Again, this example was the Bruxier. This is offered by several labs, created by Glidewell, but full zirconia restoration is my go-to when doing these cases. I think we're going to stop here since we're right on time. Any questions?
Well, before we turn it over to questions, I'm going to change the screen over to Kurt from Golden Dent so that he can, they've got a couple of specials that he's going to talk about. So Kurt, we're going to let you take it away.
All right, thanks, Lauren. I appreciate it. This is Kurt Lawler with Golden Dent. We're based here in Detroit. We started with the extractions and grafting and dental implant type products, such as like the Physics Forceps was our first product. And we've kind of stuck with that philosophy of providing simple and predictable and unconventional or different clinical solutions that work. And so if you're not familiar with us, that's kind of what started us here in Detroit. And more recently, in the last couple of years, we've been doing more related to endo, and hence the webinar this evening related to root canals. So if you have joined a webinar with us in the past, you know we usually do a promotional offer on the webinars. Tonight we'll do 15%, and the reason we do these is we go over some of the techniques and the products, and obviously if there's anything that's interesting, or maybe you're using a different file system or endomotor, it gives you an opportunity to try some of our products and then also save for investing your time with us this evening. So the discount's 15%, the code is DDS15. And our website is golden-dent.com. So be careful there with that little hyphen in the website. We do these for 24 hours, so it's good through tomorrow evening. And I'll go over this just quickly. I only have just a few slides this evening. I'm not going to get into our other products that you can see on our website related to extractions, grafting, implants, and various other procedures. We do have the comparable files to Wave 1 Gold or the Pro Taper Gold. These are two popular systems. We spent a lot of time and energy working with Dr. Nazarian and other dentists to test the files, make sure they were really, really good. And we went through lots of different versions and manufacturers, and we're very happy with this file. So the feedback's been great. If you are using a different file, whether it's the one from the actual manufacturers, or whether it's another company like an Edge Endo or another manufacturer that makes files like these systems, give them a try. You can't hurt. They're about $23 a pack, and we've been happy with them. So two file systems there that we do have currently are these two shown on the screen. So the Woodpecker brand, maybe you've heard of it, maybe you haven't. We've been extremely happy with it. We've been representing the brand now for a couple of years. And the newest version of this AI motor, it's called the Dr. Yoshi Teriyuchi motor. He's an endodontist out of Japan that made some improvements to the motor for bypassing a ledge. And there's actually there's a nice 1 millimeter vertical stroke contra angle that sort of has a watch winding or pecking type motion that allows the file, if it ever were to get hung up on a ledge, to safely bypass that ledge with ease. And there's lots of videos on our website explain what I'm discussing here this evening that kind of show it clinically in the Canal. But it's a really great motor beyond, looking really cool, obviously, with the black and the gold and the red and gold. It's a great endo motor at a fair price. The Apex locator, it's now the Woodpex 5. I noticed in the presentation this evening, we did show the Woodpex 3. But this is the latest and greatest version. they keep making it better and better and eliminate a little bit more interference that they found in the system. And this one's extremely accurate. So that's the new Woodpex 5 in the rose gold color that I'm showing on the right-hand side of the screen. The AI motor does have a built-in apex locator, but some people just like the larger screen and just use the separate one. But either way will work just fine. So with the Woodpecker brand, I just wanted to mention, so here at Golden Dent, we're very familiar with the product. We will set up, 15, 20, or 30 minutes, whatever it may take to get you set up with the Endomotor. So it's a great service we have, like instead of buying it on eBay or some other site, and then you kind of get the product, you're not sure what to do with it. We have a great staff that sets you up with your file system, whether it's a reciprocating mode, goes through all the features, programs it for you, and get you ready to go so you can use it in the future. So we do have great service in regards to supporting the Woodpecker brand products. This is the obturation system. I know we didn't show this evening, but there's a obturation gun, which is the FIG, and then there's the pen component, which is the FIP. There's lots of videos on our website. I just want to mention we do have this if you're looking for something in terms of an obturation system for the gutta percha. This is a nice system and heats quickly, has different temperature settings and all kinds of nice tips, which you can see on our website. We went over this in detail, so I'm not going to touch on this too much more, but we do have the endo irrigation and the side bent needles that Dr. Nazarian prefers in his presentation or in his office. There's a lot going on this slide. I just wanted to mention quickly, we do have really nice fiber posts, titanium pins, and metal post options. These are Swiss products, very high quality, and they're a great price. So if you're currently using, whether it's Parapost or from 3M or Pentron or any other market leader, these are really good alternatives if you are using a fiber post or a pin type system. The savings on this will be pretty substantial if you take a look. The Endoaxis Burs and the safe siders we already discussed. We obviously have the matching K files and the paper points, and the gutta percha that goes with the golden taper or the Wave 1 equivalent or the Pro Taper equivalent files. And then one other thing I want to mention is we do have these Endo Handles. It's kind of a nice product. It's just for more of getting access back to second molars with the initial glide path type K files. Just allows you to, instead of using your fingers, something to take a look at. We've found some dentists find this product to be quite helpful in the initial canal management. So lastly, before I talk about our CE, I just want to mention we have all the Woodpecker products. So we have the curing light has been extremely popular, very affordable. And then we've been doing really well too with the electric motor or the electric handpieces. So there's two versions. One has its own standalone water tank, which is quite nice. And then the other one you actually just use or hook up through your dental chair. They have great implant motors, bone piezos. We'll have their laser soon. It's supposed to have FDA approval any day. And if you're looking for any of these types of products, just remember the Woodpecker brand. We've been very happy with it. So for education, we've done a lot of programs with Dr. Nazarian for, I maybe coming upon 15 years or so now. We do them all here in Detroit. So we do live patient programs, we do classroom programs. We kind of have a nice mix of some different opportunities here in Detroit. I know this date's a long ways out. We just did a endo for the GP class. I think it was in March. So it looks like the next one we can squeeze in isn't until October, but keep that in mind if you're looking for more of a hands-on, comprehensive class and much more than we can obviously cover on a webinar in 1 hour. Take a look for the endo for the GP class. As I mentioned when I first started speaking, we started with extraction. So we still do a lot of live patient extraction classes. We have one coming up this weekend with 20 doctors. We'll see around 100 patients, and it's all live patients. So if you attend our program, you get to do the extractions. and learn extractions and simple socket preservation on live patients here in Detroit. We also have another course coming up in 2 weeks. I think this one's almost full too. This is a guided full dental implant reconstruction course. I just wanted to mention it. I know the timing on this one is coming up quickly, but if anybody's somewhat local in the Detroit area and wants to make the trip, we could probably squeeze you in for May 20th and 21st. And then lastly, here in June is our extractions and grafting program is coming up. And you can learn all about these classes on Amplified Dental Training. I just wanted to mention these quickly why I have your attention. We have a lot of really nice live patient and classroom-based programs that are all led by Dr. Ara Nazarian. So if you enjoyed his presentation this evening, he teaches our endo, extractions, grafting, and dental implant classes also. So I'll leave this up here. I'll turn it over to Lauren and Dr. Nazarian for the Q&A portion, and the code is DDS15. And give us a call if you have any questions. We're more than happy to help you out and answer any questions you have related to our endo products. Thank you.
Thank you, Kurt. Ara, you ready for some questions?
Absolutely.
Well, one of the first ones are ones that I can answer. People are asking about the recording in the CE. I mentioned this at the very beginning if you came on a little bit late. The recording typically will go out in about 2 or 3 days. The CE usually takes a little bit longer than that, a week, week and a half. Feel free to reach out to me if you don't have it by next week. But as long as you are on for the bulk of the webinar, you will get the CE. There's nothing you need to do. You just log out at the end and it gets sent automatically. Okay, first question. How do you place that funnel in the hard palate? And do you anesthetize the patient first and then insert that funnel?
I'm sorry, I didn't understand that. How do I place the what? Funnel?
The funnel? I guess you showed, I don't remember actually what it was. Was it a funnel?
I think it was the X-tip system, Ara, as Eddie's mentioning.
Oh, okay. So there's a rotary drill with a metal sheet that comes with the X-tip. So you just use your regular slow speed, and because that little sheath is so sharp, it actually pecks through the cortical plate, leaves that little channel there, and then you dispense the anesthetic through the channel. The Stabident, which is another company's, just has a drill that it's a disposable drill, excuse me, that you use for each patient. But it was difficult to find that hole because it's just a little pinhole through the cortical plate. So that's why I think X-tip came out with a little channel that stays in. So as you drill it, it leaves that metal sheath in, and then you would just dispense the anesthetic through the metal channel, and then you just use like a hemostat and you pull it out. Obviously, you don't want to leave that in there. I'll leave it in during the procedure if it's a hot tooth and they may need some more anesthetic, but for the most part, it works very, very well.
Okay. You showed that chart where you had the different types of teeth and number of roots they have. Do you ever see 3 roots in first premolars?
I've seen it once or twice, but usually it's not enough that they put a percentage that was that great on there. So would you see it? Maybe in your career. I've been practicing 27 years, but very rarely. I would say very rarely.
Okay. You talked about the different rules. What was the rule before the rule of concentricity?
So the rule of centrality, which just means you want to be center of the tooth.
Right. Okay. How many times can we use the files? How many canals?
I suggest to just use it once for such a small fee for these files. I've never even attempted to reuse them. Kurt could probably answer that question, but I mean, at such a small fee, I would say do not reuse them.
Okay.
I used to have friends that would make notches on their files, you know, when they were paying big money for the Pro Taper files and things like that, and make another notch if it's been sterilized twice. There's no need to do that. These files are so inexpensive, I would just use it as a single dose. That's it.
Okay. What if you were filing and you went beyond the apex and you were getting some blood in there? You know, how would you get some type of hemostasis?
The best way to achieve that is take 2% xylocaine, put it in the canal and inject, you'll have some resistance, but because of the vasoconstrictor in there, you're gonna get hemostasis for a while till you
Okay.
dry it and fill it. Now, it all depends on how far beyond the apex the operator goes, right?
Right. I mean, if you're in the sinus,
Yeah,
all bets are off.
you may have a little bit of a problem, but if you've gone out like half a millimeter or a millimeter, then you can obtain hemostasis by using the 2% lidocaine.
Okay. How do you feel about carrier systems?
Carrier systems like the hot gutta percha carrier systems, I think
And
they
they don't
work very
specify, but yeah.
well.
Okay.
I'm assuming that's what they're asking. I'm assuming they work well. They are much more costly. You do need an oven for that. And it's a proprietary thing, so you're not really mixing and matching um, systems. But most importantly, if you go to retreat it, I know they have a special uh, gates or burr to create post space, but because of the filament within the that obturation system, it becomes a little bit more difficult. Do they
Okay.
work? Yes. I'm more of a single cone type of person without the carrier.
Okay. Let's see. I'm going to combine a couple of questions here. What's the dose of dexamethasone, and what's the regimen to combine ibuprofen and dexamethasone?
So I have the 4 milligrams of dexamethasone, which is also called Decadron. Within our practice, you could get that from Shine or any other pharmaceutical distributing company. We're obviously going to indicate in the chart that we dispense that one. Usually, it's recommended to do it before treatment, and that way it helps prevent inflammation better than if you'd give it post-operative. However, it does still work post-operatively. Is better than giving nothing. And for those cases where you may have over-instrumented, it definitely helps keep that very calm.
Okay.
So you don't even have to do it with Motrin. You can just give them that if you wanted, and not do the
Sure.
Motrin.
Yeah. Okay. What solution do you use for irrigation, i.e., sodium hypochlorite or glutaraldehyde or something else?
So we're just using the sodium hypochlorite that's pre-mixed from Golden Dent. I found that when the assistants were taking sodium hypochlorite and diluting it, they were never really diluting it to the appropriate level, which should be about 5 to 6%. I mean, I've spoken to people that don't even dilute it, excuse me, and are using sodium hypochlorite, you know, uh, at its full capacity, and then they wonder why they have all this irritation and post-op discomfort.
Okay. Would you recommend to seal the canals with something like Gutta Flow 2 or mixed Gutta and sealer to seal the voids?
So the sealer that we indicated is the one that I use, but all the sealers work out there, and especially the more recent sealers are usually some type of resin with a glass ionomer, so a resin modified glass ionomer. I know some companies have like a bioglass ceramic type of sealer. I mean, it's really what you're comfortable with. I try to keep things, like I said, fast, effective, and predictable. And if I find that patients aren't complaining of it and the root canals are successful and they're not coming back with periapical lesions or issues, then excuse me, then I'm going to keep using the system.
Sure. Do you use cone beam to check on axis shape in advance? I find sometimes hard to find anterior axis, either upper or lower.
Absolutely. I have the Carestream 8100 within my office, so it's not an issue to do it. Usually if we scan just a small region, it would be a 5x5 window. So we're not scanning the whole mouth. We're just scanning a quadrant or a few teeth. And so, yeah, absolutely. That's a great question. So if I'm doing a 5x5, we're charging about $75 to $90. If we're scanning an arch, it's $150. And if we're scanning upper and lower arches, in other words, a full mouth, then it's $275. And so it definitely will make you a better comprehensive dentist, whether you're doing root canals, extractions, or implants. I highly recommend getting CBCT within your practice.
Okay. What do you think of doing the access before placing a rubber dam in order to help with orientation, especially when a tooth may be severely broken down or rotated or not in a normal occlusive relationship with adjacent teeth?
Yeah, I think that's a great idea. A lot of doctors prefer to do it that way before they put the rubber dam so that they can actually visualize the long axis of the tooth. So if you want to access the tooth that way, that's not a problem. Just make sure your assistant's there with the suction in case, somebody's got like a large amalgam restoration. Uh, but no, you could approach it in that direction. And in some cases, I actually have done it that way where I'm like, God, this tooth looks like it's angled. I don't really know which way I should access this. It's sort of rotated. So that's a great suggestion, and I do use that sometimes.
Okay. How many tabs of dexamethasone, and follow-up question or another related one, is only one tablet enough, or any antibiotics required on completion of the root canal therapy?
Yeah, so you're going to use your assessment in these situations. If there's a periapical lesion, then I would highly recommend giving the patient RX of amoxicillin. I used to do the 500 QID for 7 days, and I quickly found that patients aren't taking 4 tablets, uh, you know, so they weren't really getting the appropriate dosage. I quickly realized that if you do 875 BID, which is twice a day, then patients are more inclined to do it after breakfast and after dinner, and the amoxicillin is the go-to. If somebody's allergic to the amoxicillin, then we'll use erythromycin. And if they're allergic to erythromycin, then the next antibiotic in our protocol would be clindamycin. So usually it's amoxicillin. If they can't take that, then it's erythromycin. And if they can't take that, then clindamycin.
Okay. What about in your hands? What are there situations where you might do like a multi-visit versus single visit with calcium hydroxide for necrotic teeth? Especially if there's an obvious lesion there.
Yeah, so in some cases, if I find that there is some calcification, then I will actually let the EDTA sit in the tooth for several minutes, start with a small file, and usually the EDTA solution works very well. I used to use something called RC Prep, which is more like a paste that has EDTA in it, but I found it didn't get into the area as nice as a liquid would. So usually I would say 98% of the time I am finishing the root canal day one. Now, again, if they're in between patients, I'm running behind, I'm obviously not going to sit there and try and finish a root canal. I may just do my filing and everything, remove the tissue, and then maybe just put a cotton pellet with some Cavid on there. And, you can use whatever solutions you want to irrigate, dry it, and then close it up. Some people like formocreosol, some people like a variety of different solutions. Usually I'm just putting a dry cotton pellet in there and coming back in, but usually that's only what, 2 to 5% of the time.
Yeah. Are you currently using some type of agitator like the endo activator to move the irrigants around?
I am not.
Okay.
I have seen those. I tried 1 or 2 of them as just a demo, and I didn't find that it was doing anything. However, they do have a lot of research. I just don't have I don't have the experience to, comment on it.
Okay. A couple of related questions. In your opinion, is the single cone technique as effective as backfilling with warm vertical like just shown? And how do you feel about traditional lateral condensation?
Well, I think lateral condensation is great. It's just technique sensitive. And so I think all the systems work and all the different techniques work. What I found works best in my hand is the single cone technique. Um, However, people do backfills all the time and they're successful as well. I can say it's definitely going to be more costly and more technique sensitive,
Okay.
at least in my hands, I should say. For
Okay.
specialists, that's what they do all the time.
Using a resin sealer, does it require etching the canal, or does EDTA prepare it for sealing?
Yes, you do not have to prepare it with etch.
Okay. Do you always end up? Do you always end up single cone obturation, even large canals seen in central incisors?
So usually you'll have gutta percha points that go larger in size. However, if necessary and you need an extra canal, extra cone for the canal, then yeah, that's not a problem. We can
Okay.
use that.
At what point would you retreat a case that you just completed? For example, you used F2 finishers, you followed your best techniques, but you still have some postoperative discomfort for a period of time. When do you instrument to a larger finisher, or when do you introduce antibiotics in that point?
So there's a lot of variables of why they may have sensitivity, and is it sensitivity or did the operator not get the whole pulpal tissue out? I would say whenever possible, at least try to go up to a 25 or 30 size file, red or blue, depending on what system you're using. Number one. Number two, you want to make sure that you get to length. So if a tooth comes back that I did, well, or somebody did, and I see that the gutta percha is not going down the whole way, then I'm going to question, was this root canal successful or not, if they come back with discomfort. So there's so many variables to look into to make a decision at that point. But yeah, I wouldn't. If you're redoing a bunch of your root canals, then you didn't do it right from the first time.
Okay. What about a tooth that's just pumping pus out, like just like a volcano? Do you leave them
Yeah,
open for a time to
we're
let them
not gonna
drain,
fill
or?
that. No,
Okay.
there have been times where I actually have left it open to just drain. If they have a large swelling in their face, put them on an antibiotic, remove the pulpal tissue, and just let the tooth drain.
Okay. What about
And put them on
isolite?
antibiotic, obviously.
Okay. Yeah. Could you use isolite like equal to a rubber dam isolation as
I don't
when you're doing
know
these?
if isolite stands up in court if somebody were to ingest something. I don't know the answer to that. I have seen isolite at the shows. I had somebody put it in my mouth. For me, it didn't feel that comfortable. Not that a rubber dam does. Um, so I don't know um, how that would apply if somebody were to take something in
Right.
and they didn't have a rubber dam.
And that's
It's a
so
good question to
basically,
ask the company. Yeah, I
would
do
you ever
rubber
would
dam
you ever do an
everything.
endo? Would you ever do an
Uh,
endo without rubber dam? Would you
uh,
ever?
I wouldn't suggest it. Have I? Yes, I have.
Of course. I'm not sure if I
So
understand the
that brings
question.
up a great
Yeah.
question, Lauren. So let's say a tooth is broken down. There have been times where I've actually put the rubber dam clamp onto the gum because the clamp keeps popping off, just to keep it in place to do the root canal and then do what I need to do. Usually if I'm not using a rubber dam in a particular case, it may be like an anterior case where we have some cotton rolls, the suction's right there, we have a throat pack, if let's say the patient's sedated or something like that. But usually a posterior, we're always having a rubber dam.
Yeah, put it on the gum. That's like a instant crown lengthening.
There
Don't
you
have to.
go.
The last question here. I'm not sure if I completely understand the question. Restoring the severely decayed tooth before root canal is suggested?
I'm sorry, they're asking what now?
Yeah, I'm reading that verbatim. Restoring the
Okay.
severely decayed tooth before root canal is suggested.
So one thing the audience has to remember is that now we have something called a dental implant that has a great long-term prognosis. And although our oath is to try to save teeth as much as possible, if you find that the decay is so extensive, then I would rather you take the tooth out and put an implant in.
Yeah, that makes
So
perfect
that's what
sense.
I do in my practice because I also place implants, as you know.
Yep, I
But
do know that.
again, it depends on what they're presenting with, what's left. Does it have a long-term prognosis? I mean, if you're doing a root canal, core, and a crown, or even crown lengthening, you're spending several thousands of dollars, let's say at least $2,500 on that tooth. So you want that to last at least 7 to 10 years, I would imagine. So if it doesn't look restorable, I would take it out and put an implant in.
Yep. You're a GP, right? I mean, this is what you do
Yes,
every
I
day.
am a general. Yes, I am a general practitioner. Yep.
Well, we are at the bottom of the hour, so Ara, I'll let you kind of give a closing comment, and then I'll close. Then I'll finish it up for the evening.
Thank you, Dr. Levine. So I've had the opportunity, the honor to be able to work with Dr. Levine and Golden Dent for many, many years. And so what we try to talk about is, general dentists implementing a variety of different services in their practice, whether it's extraction or graft, root canals, or even dental implant placement. Our goal is to try and teach that to our general dentists. And it doesn't mean you have to do every case that's out there. But if you just increase by 15 or 20%, do some premolars instead of just doing the anterior teeth with the proper training, or start extracting more teeth and grafting and setting the foundation for implants, I think you'll find that dentistry will be even more fulfilling because you're able to be even more comprehensive, but it'll be very gratifying to your practice. And you look forward to doing some of these things outside of just the general dentistry um, services. And sometimes that opens the door to cosmetic dentistry, because what we're finding now with reconstructive dentistry in our practice is that patients are presenting and they may need 2 root canals, 1 extraction, 3 implants, and 4 crowns. And so what I'm finding is patients don't want to go to 3 different dental providers for all the different disciplines. If they can have it all done under one roof, then that's beneficial for them. And if you can provide that for them, obviously within your comfort zone or with further training, I think you'll find dentistry really rewarding. So
Thank you.
I'd like to thank
Well,
everyone and have a great night.
and I want to thank you because, like you said at the beginning, we've done about 25 of these together, and one of the reasons I love working with you and with Golden Dent is that it's not the same stuff regurgitated over and over. Every webinar is new with different cases, unique content. I thank you for sharing your expertise with us, Dr. Nazarian. And thanks to Golden Dent for bringing you on board and for sponsoring the webinar. I would highly encourage people to take advantage of the offers that were presented this evening. You can go to goldendent.com. AmplifyDental.com is where they do all the training, and certainly that's a great resource. We have many of our clients who are also clients of Golden Dent and Amplify Dental, and they rave about it. So, take advantage of that special savings, the DDS 15. We do these webinars on a regular basis. So, please keep an eye on your inbox for future webinars. As I've mentioned a couple times already, the webinar was recorded. The recording will go out sometime in the next few days. CE forms are sent out automatically. There's no quiz or registration like that. You don't have to do anything. Just keep an eye on your inbox. Those usually take about a week to a couple of weeks at the most. So, let me know if you don't get it in the next week or two. We know all of your time is valuable. We thank you for joining us this evening, and we look forward to seeing all of you on our future webinars. Good night, everyone.